So we'll discuss when to dialyze and how to dialyze our patients. So what are the indications that you are looking for when you want to dialyze your patient? Better way to classify absolute indications and relative indications. So these are some of the absolute indications that you need to dialyze your patients. Like if you have a metabolic acidosis with a pH of less than 7.1 in an AKI patient, you will need to dialyze him. A hyperkalemia with potassium of more than 6 with ECG changes, again you need to dialyze him. A pulmonary edema which is not responsive to diuresis, or to prevent the need for ventilator support, you will have to dialyze. If he is having uremic complications like encephalopathy, pericarditis, neuropathy, or you have uremic gastropathy which can lead to bleeding. So again, for these uremic complications, you will have to dialyze. And if you have certain toxicity or overdose of drugs, which are dialyzable, you will have to again dialyze. So what are the drugs that can be, or the toxins that are dialyzable? So remember the mnemonic I-STUM. I for isopropyl alcohol, S for salicylates, T for theophylline, uremia, methanol, barbiturates, lithium, ethylene glycol, and dabigatran. Right? I-STUM. So after the absolute indication, there are some relative indications where you will have to take a decision whether to dialyze or not dialyze these patients. So this is oliguria, anuria, azotemia. There is no defined limit of azotemia as to when you should dialyze. So you will have to take a clinical call. Hypermagnesemia in an anuric patient with loss of tendon reflexes, where your magnesium is more than 8 milliequivalents per liter, and anticipated worsening of electrolyte problems in AKI with syndromes like tumor lysis syndrome or rhabdomyolysis. Apart from that, there are certain conditions where the dialysis might help you. These indications have been reported by Ravindra Mehta, one of the stalwarts in the field of CRRT especially. These have been named as renal support indications. One is cytokine manipulation. This is primarily you can achieve when you are doing a CRRT, not possible in a SLED or a hemodialysis, where you are basically targeting the middle molecule clearance. We'll come to the little more detail later in the lecture. You can target the fluid management, especially if you are going by the ROSE concept or the SOSD concept, where you want to de-resuscitate your patient and his anuric or the urine output is not adequate. Again, you can take help of your dialysis machines. And nutrition. How does it help in nutrition? TPN and it decreases bowel edema, so it increases the assimilation of food if you are giving enteral nutrition. So it helps in both TPN and enteral nutrition. So there are certain goals of dialysis which you are trying to target: remove excess fluid, treat fluid overload, correct and control azotemia, control electrolyte imbalances, assist in maintaining acid-base balance. But these goals must be accomplished without precipitating any additional hemodynamic instability. This is the primary target. So these are the various types of renal replacement therapy that we are going to discuss, except renal transplant, which is beyond the purview of this lecture. And peritoneal dialysis we are primarily discussing. We are not doing it in our ICUs, but once in a while you can get a patient, or you will have a scene where you cannot even get any IV access, so that may be an indication for peritoneal dialysis. So how do you do peritoneal dialysis? You float the dialysate into the peritoneum, give it indwelling time. Indwelling time ranges somewhere around 4 to 6 hours, and then you empty it out with the help of gravity. So advantages: it can be performed in a difficult or impossible to obtain adequate hemo access. This is an absolute indication. Maybe sometimes you will have to do a peritoneal dialysis, or you cannot. And the advantage is that there is no need for anticoagulation when you are doing peritoneal dialysis. Disadvantages are that you will have a substantial protein loss. There is increased risk of peritonitis because you are repeatedly instilling a fluid from outside into the peritoneum cavity. There can be drainage difficulty. You have a catheter block, you are not able to empty it out, and because you have put the fluid into the abdominal cavity, there will be elevation of diaphragm, thus affecting your lung functions. Because the fluid which you have put in peritoneum can translocate to the pleural cavities, you can have hydrothorax. And because the solutions which you have for peritoneal dialysis have high concentration of glucose in them, so you can have glucose and electrolyte abnormalities. And obviously, if you have put a weight in somebody's tummy, it is obviously going to restrict the mobility. So if you want to target solute removal, you will have to increase the dialysate volume, and you have to increase the dwelling time. So it gives more time for solutes to cross the membrane, and the membrane here is peritoneum. And if you want to do the fluid removal, there should be increased concentration of glucose in the dialysate, and dwelling time should be less. Less because once the fluid has come back, it gets diluted, and then if the concentration is not adequate, it can go back again. So shorter dwell time compared to solute removal. Complications you have with peritoneum peritonitis, one of the primary complications that you can have, which can be as abdominal pain, nausea, cloudy dialysate effluent, and loss of ultrafiltrate. Coming to the hemodialysis, which is our primary objective of this topic. So when you are doing a hemodialysis, you need an access. Access can be permanent or temporary. Permanent access can be in the form of a fistula that is created surgically, or it can be a permacath if the patient is on a long-term dialysis, like a CKD patient who has come with acute complications. Or you can have a temporary dialysis catheter, which is primarily placed with the IJV or a femoral access because they are more straight venous accesses. Subclavian generally not preferred, primarily because the site is difficult to approach. If you have a bleed, difficult to compress, and because of the angulation, you're likely to have more turbulent flow compared to the other two accesses. So the subclavian is the least preferred one. And this is a diagram for your how the hemodialysis circuit is. So once the blood comes out, there is first a monitor which measures the arterial pressure or the pressure of the blood coming from the access pressure monitor, you can say. Then there are two pressure gauges. This is the dialyzer inflow pressure monitor, and this is the venous pressure. So pressure across this is your filter pressure, right? So this is a basic structure of the filter. Filters are generally hollow fiber membranes, and around them there is the dialysate. So the blood is flowing inside this red dots. These are the hollow fibers, and dialysate is all around them. 99% are like this, but sometimes you can have disc filters also, which are solid disc stacked over each other. Now coming to the membrane material, it can be a cellulose material, substituted cellulose, or a cellulose synthetic, but none of them are in clinical use as of now. What we have are the synthetic membranes. So the most of the membranes you are using for a hemodialysis filter are polysulfone filters, and the ones which you are using for a CRRT are polyacrylonitrile filters, right? They can be polyamide also, polymethyl methacrylate filters also. Now the issue is that when you are using your natural fiber filters like the cellulose or the semi-synthetic ones, you have bioincompatibility issues. So it is a measure of the propensity to activate complement, coagulation cascade, and leukocytes. So cellulose membranes are the least biocompatible, so they will have maximum activation of these, while synthetic membranes have these are the most bioincompatible. You must have seen sometimes you start dialysis first time for the patient and is suddenly having hypertension and is having dyspnea, breathing difficulty. These are all bioincompatibility issues because of the filter membrane. So sequelae of incompatibilities, you can have prolonged renal damage, greater tendency of filter clotting, and prolongation of impairment of hypercatabolism, increased risk of and infection. Now coming to the dialysis fluid. There can be bicarbonate based dialysis fluids, acetate based, lactate based, and citrate based. Citrate actually plays dual role, especially if we are talking in terms of CRRT. It can be a bicarbonate donor as well as it acts as an anticoagulant. So bicarbonate is the primary dialysate that you are using. It is more physiological and it is but a highly unstable one, and calcium magnesium can precipitate as carbonate when sterilized with this buffer, and there is apparent predilection for bacterial growth. So you have seen two boxes, दो डब्बे रखे होते हैं dialysis machine के आगे. What are those? Anybody? State loudly. One of them is bicarb. What is other? So you have two boxes in front of your dialysis machines or the sled machines. So this is part A and this is part B. So part B is basically what is your buffer solution. So this is freshly made bicarb, and if you see here, there is no bicarb in part A, right? And if you can read closely here, it is that used within the same day to avoid CO2 loss and to minimize precipitation. So this is the part B, which your technician will come to your dialysis unit or ICU unit and freshly prepare at the bedside and start your dialysis. Acetate, less commonly used, has respiratory and vascular complications like vasodilation, myocardial depression, and increased oxygen consumption. Lactate, again rarely used, it undergoes hepatic conversion to bicarbonate on equimolar basis. However, avoided because of lactic acidosis, hyperlactatemia, hepatic failure, and even if you can have problems in measuring your lactate levels in sick patients. Coming to the anticoagulation. So anticoagulation, only first three are of clinical importance. These three are only theoretical importance. So heparin is, so if you are doing hemodialysis or a sled, you can do it anticoagulation free. What your anticoagulation primarily require is for CRT, because it is a 24-hour ongoing process. So if you do, and a low flow system compared to your hemodialysis. So there you are, always need an anticoagulation. So it can be heparin, and what is the dose you are trying to target? Generally, you give a 25 units per kg loading dose and then 5 units per kg per hour, targeting an APTT of 60 to 70 or 70 to 80, somewhere in that range. You can also use low molecular weight heparin, and you can use citrate in the form of regional citrate anticoagulation. So what happens is, when you are accessing the blood from the access port of the dialysis, citrate gets mixed there and you have a regional anticoagulation, and when the citrate, this blood which has citrate is going back to the patient, you give calcium at the other end of the dialysis catheter, it chelates your citrate, and so you have just the anticoagulation in your citrate circuits, while the blood or the systemic circulation does not receive any anticoagulation. We'll take questions at the end. Right? And this regional heparinization is, somebody has romanticized, I don't know why, but this is completely unphysiological thing to do. You give a pre-filter heparin and post-filter protamine. First, the half-lives of these two things are absolutely different. Right? Heparin has a half-life of somewhere around 90 minutes, while protamine has a half-life of 5 minutes. And a protamine has significant side effects, flushing, coagulate, your complement activation, all those things. So it's absolutely not to be used in a clinical practice. But if you have a theory question, you can obviously write it down. Now coming to the how the dialysis works. So there are three things we need to know: ultrafiltration, hemofiltration, and hemodialysis. So we'll start with ultrafiltration. So ultrafiltration is nothing but basically movement of fluid from high pressure system to a lower pressure system, right? So this is what is happening. You have a pump here which is pushing actively the blood into this system, and you also have a pump here which is actually sucking out things from this chamber. So it is creating a negative pressure here. So a positive pressure here and a negative pressure here, and thus this helps in exchange of fluid, which we called as ultrafiltration. Now if your ultrafiltration is having solvent drag with it, which is basically dependent on the pore size of your membrane, this is actually known as hemofiltration. So now this is basically dependent on sieving coefficient, which is ability of solute to convectively cross the membrane, and the ratio of solute concentration in the ultrafiltrate to the concentrate in plasma. So this is basically the ratio that how you can calculate sieving coefficient. And so sieving coefficient of 1 means that the solute freely crosses the membrane and is removed in the same concentration as the plasma. And sieving coefficient of 0 means that there is no solute removal due to either large molecular size or extensive protein binding. So this is the actual picture of a sieving coefficient that is given in your CRRT filters. This is the information which is given on the M100 filter that we use in routinely in a CRRT. So you can see the sieving coefficient of urea and creatine, which is the most permeable thing, is 1. So freely permeable. Next we come to hemofiltration, which is basically removal of relatively large volume of fluid by ultrafiltration, resulting in removal of solutes through convection. Right? So ultrafiltration, hemofiltration are convection based methods, and when you have solute clearance along with water, it is known as hemofiltration. Only possible in your CRRT machines, and you have to give replacement fluid because you are having a lot of fluid loss. So you have to give some amount of replacement fluid when you are doing hemofiltration. So this is a line diagram of a CVVH mode, that is continuous veno-venous hemofiltration, which you do in your CRRT, not in your routine hemodialysis machines. So again the blood is going positive pressure here, negative pressure because of the pump here, the fluid gets translocated, and depending on the sieving coefficient you will have some translocation of the solvents. Primarily the molecules which are cleared by the convective forces are the middle molecules, right? And this is why CRRT may be of some benefit, although not proven in studies, compared to your routine sled or the HD machines. And once this function has taken place, you will have to give some amount of replacement fluid to replenish the volume. So now your replacement fluid can be pre-filter or post-filter. If you are giving pre-filter, what you are basically doing is you are diluting the blood. So there is less clotting of your filter, less sludging, and the problem is that you are decreasing the concentration of the solutes in your blood. So you are decreasing the gradient for filtration. So this is where you have to give your pre-replacement fluid. This is the filter, blood is coming from here. This is blood pump, and you add your replacement fluid pre to the filter. Right? Any confusions? No. So if you want to add post, you will have to add after the blood has been filtered and it is going to return to the patient. Then you add your post replacement fluid. So you can add either pre or post. Not go into more details, but you can have both the things also. Machine gives you only option of selecting pre or post when you are doing CRRT, but there is an option of pre-blood pump also. If you have taken pre-blood pump, it is acting like a pre-replacement fluid. I will not go into detail, don't get confused. If you have time and if you like to visit our ICU and if there is any CRRT machine, we will show you there. Right. So after ultrafiltration and hemofiltration, we come to diffusion. So diffusion is movement of solutes from area of higher concentration to the area of lower concentration. So dialysis uses a semi-permeable membrane for this diffusion process. So this is they are going in opposite direction. So if the blood direction is like this, the dialysate flow is like this, and this is a semi-permeable membrane, and diffusion happens across this membrane. So this is dialysis, which is based on principle of diffusion. So if somebody is saying hemodialysis, he means diffusion, and if he is saying hemofiltration, he means convection, right? So this movement of small solutes by diffusion through the addition of dialysate to the fluid side of the filter, and they move from their higher concentration to the lower concentration, and direction of the blood and dialysate are opposite to each other. So a line diagram again of the CVVHD, continuous veno-venous hemodialysis. So everything is same, but there is no replacement fluid. Direction is opposite, and you have the effluent bag here, and you are putting dialysate from the opposite end. So if you combine both these things, what you have is hemodiafiltration. So you are using both the techniques in hemodiafiltration. You have a dialysis thing, your solutes are moving from higher concentration to lower concentration, and when your dialysate and blood are going in opposite direction, and you are also using the benefit of convection to do hemofiltration. to remove primarily the middle molecules and the fluid. So this is a combination of everything. Here you have replacement fluid, dialysate, anti-clockwise, opposite directions, right? And everything is getting accumulated into the effluent bag. What is the dose for CRRT? That this is a very common question in Viva. What is the dose of CRRT that we are targeting? 20 to 25, not 25 to 30, right? ml per kg per hour. And everything gets added to calculate the effluent dose, your replacement, your dialysate, ultrafiltration. When you add everything up, you have your effluent dose. So just to review again these things. So if you are doing scuff, slow continuous ultrafiltration, you are just removing fluid here on the principle of convection. If you are hemofiltration, you are adding some amount of replacement fluid while you are doing ultrafiltration. If you have hemodialysis, there is a dialysate you are adding at the other end compared to the blood and removing it from the other end. And if you have hemodiafiltration, you combine all these things. So again we revise. CVVH is based on which principle? Continuous veno-venous hemofiltration. Which principle? Convection. CVVHD, hemodialysis, diffusion. CVVHDF, convection and diffusion. Scuff, convection or ultrafiltration. Right. So now there are two pressures that are important when you are doing your dialysis. That is transmembrane pressure and pressure drop. So transmembrane pressure is basically pressure difference between the blood and the fluid compartment, and it is calculated by filter pressure plus return pressure divided by 2 minus the effluent pressure. Now what TMP is basically, it rises when your hollow fiber membranes get coated with the protein in the debris. So when your any dialysate or whatever is the exchange happening between the blood and the other side, it decreases that. So whenever the coating happens, your TMP rises. It is not depicting the block of the hollow fiber, it is just depicting the coating of your the filter. Next is the pressure drop. This is the pressure going through the hollow fibers of the membrane. So if you have a rise in pressure drop, it is actually telling that there is some amount of clot happening in the fiber, right? And it can be calculated by filter pressure minus the return pressure. So molecular size is important when you are doing your dialysis. So again, as I told previously, when you are doing convection, you are primarily targeting these middle molecules. Why middle molecule is important? Because all your cytokines, which are the inflammatory markers, are the middle molecules. So you can have some amount of this clearance when you are targeting the middle molecules using your convection. Just the diagram state about various therapies, but what is important for us is the blood flow rate. So highest blood flow rate is obviously in the intermittent hemodialysis, where it will go from 250 to 400 ml per minute, while all others are more or less in the same range, whether it be SLED or various forms of CRRT. Now comes the question of timing of CRRT. When do you start your renal replacement therapy? So these are all the trials that have been published from 2016 till date. These are all the important trials. I believe Dr. Sachin must have covered in his lectures, so I am not going into the details of this. What is important for us is that except for the ALIGN trial, which was in 2016, one of the earlier one compared to all the others, which favored early RRT, there has been no difference in all the studies when they have compared early versus delayed RRT or delayed versus, which is the AKI 2 trial, delayed versus more delayed trial, indication for dialysis. So problem with the ALIGN trial was that primarily more than 90% of the patients were of the surgical subgroup, right? And even the patients who were randomized to the delayed group were actually just critical 3 less than 12 hours. None of them had an absolute indication. So maybe that was even an early kind of thing compared to other trials. So that's why maybe this study has and favors an early RRT compared to all the others. But you need to know this study, especially if you have a long question in your DM or the DNB exam. You will have to mention them at least some part to score more marks. So timing does not make a difference whether you are doing late or early. You can choose as per your convenience and convenience of the patient and his requirement. Coming to dose of CRRT. So except the Ronco study, which was the one of the early studies in 2000, where they compared 20 to 35 to 45, where they found 35 and 45 were better compared to 20, but there was no difference when they compared 35 to 45. All other studies have found no difference, whether you are doing 40, 25, 35. So problem is you can do high dose CRRT. Problem is the cost. If you are doing 40 ml per kg per hour, you are increasing the rate of the fluid that is being consumed. Each bag costs around 5,000 rupees. So you have 3 bags which are attached to your CRRT machine. So high dose does not make any difference to the patient, but it makes a lot of difference to the attendant. He'll come and fight with you. So do it at 25 ml per kg per hour, that is sufficient. So advantage of CRRT, suitable for use in hemodynamically unstable patients. Precise volume control, which is immediately adaptable to changing circumstances, rapid control of metabolic acidosis and hyperkalemia, improved nutritional support, available 24 hours a day with minimal training, safer for patients with brain injuries. This is actually one of the indications where you can use CRRT over your hemodialysis. If you have brain edema like ALF patients, you can actually go for CRRT because there is a more gradual removal of fluid which can avoid sudden fluctuations in your ICP and may have an effect on the adjuvant therapies in sepsis as we discuss cytokine clearance and probable advantage in terms of renal recovery, which are shown in few studies, but conclusive evidence for any of these is actually lacking. Disadvantage is a very expensive therapy. The filter costs around 18,000 rupees, the bags cost 5,000 rupees. So overall, once you are initiating your CRT, it comes around to 80,000, 60,000 rupees, somewhere in that line, compared to the routine SLED or HD, which is somewhere in 20, 25,000 rupees. Anticoagulation is a must when you are doing CRRT. You can go for citrate or heparin. The risk of line disconnection, it uses a lot of nursing time. Because it's a continuous process, you have to change bags, you have to empty the influent bag, so it takes up a lot of nursing time also. And because you have put a patient on extracorporeal circuit which is running continuously throughout the day, you will definitely have a hypothermia when you have a patient on CRRT. So when they have compared continuous versus intermittent renal replacement therapy, they have not found any difference. If you look at this forest plot, absolutely no difference. If you look at the mortality difference, again, not different, except for one only study by Ravindra Mehta. And this Cochrane review, again, intermittent versus continuous renal replacement therapy for acute renal failure, no difference here also. So CRRT offers no survival advantage over intermittent renal replacement therapy in patients with AKI. Patient survival with AKI who are managed with CRRT have a similar expectation for recovery of renal function as those treated with RRT. RRT is associated with significantly higher MAP. This is an actually advantage where you will have a very sick patient on double or triple vasopressor support. And CRRT is associated with significantly increased risk of recurrent filter clotting compared to intermittent renal replacement therapy. So why not accept conventional intermittent hemodialysis? One problem is inadequate uremic control because it is an intermittent form. Your patient is too sick, so there will be more generation of urea. Hemodynamic instability, if you do it at 400 ml per hour, nobody can manage the blood pressure there. Poor fluid control again because of the intermittent, poor electrolyte control, poor acid base control, and serious limitations on nutrition. All patients who are on dialysis will have protein loss, right? So is there a way out? So the way out is doing SLED, hybrid therapy. So you use the same nephrology machine, dialysis machine which you are using for HD during SLED. It is an intermittent form, but you are using for a longer duration, preferably 8 hours. And your solute and fluid removal is at a much lower rate. And even the blood flow is at a lower rate. So you can manage your patients hemodynamically better. So pros are it allows fluid removal with minimal hemodynamic instability, consistent solute control, independent of the availability of a trained HD staff. I don't know why. Who manages CRRT in your unit? Do you do CRRT? How many do CRRT? Not our fellows. So in our unit we do CRRT from placing the circuit to removing it, and the nephrology staff is not involved. And the pros for hemodialysis are that it is inexpensive, intermittency and downtime, allowing for out of unit procedures. If you want to take your patients for CT and other procedures, IR reviews, all those things, and you can treat more than one patient with one machine. If you have a CRRT, it is attached to one patient, you cannot do or use that machine for another patient. So to summarize, although there is no formal evidence to show superiority of CRRT over intermittent, CRRT has become standard of care in management of hemodynamically unstable critically ill patients with AKI. Higher intensity therapies offer no significant advantage over low intensity therapies in critically ill patients. Controversy remains about the timing of CRRT, and newer technologies had been advocated for management of sepsis. They are not new anymore. So all those filters which have polymyxin coated and cytokine evidence is very poor, but you can use them along with your dialysis machines. So thank you. And this is very important if you are practicing CRRT. If you hear about CRRT, you will definitely forget it. If you see it once or twice, you might remember it. But if you do it every day, you will definitely understand it and you will realize it is one of the easiest things to do. Thank you.